Good evening, everybody, and welcome to that chat. We have one of our guests on the move. So while she's getting herself settled, I am going to thank our sponsor, My Girl Managed. If you have a business that needs help with your digital presence, check out My Girl Managed Services. They can help you with your website, your Google presence. They can help you with your social media, anything for an existing or new business where you need to get yourself seen, heard, and be the first one that people check out when they need you. Check out My Girl Managed Services. We are so happy to be here tonight on this beautiful sunny. It was supposed to be a really not a great day in northeastern Pennsylvania, but it turned into be a sunny, gorgeous day for our next edition of That Chat Health Series. We are so excited to have our very good friend, Dr. Ranju Gupta, with us again. Hi, Ranju. How are you doing tonight?
I'm doing very well, Holly. Glad to be back here, and it looks really beautiful. It's a little windy outside.
It is. You
I
know, the
have,
thing about it is, it's still just spring
that's
in
right.
Pennsylvania, which could mean a lot of things. That's a lot of it. It could mean it's cold and windy, or it could mean it's 82 and humid. It could go back and forth like 20 times in the next couple weeks, right?
It just looks like that. Yeah, I'm just kind of thinking when to bring my plants and kind of put them through. Just because last time we did that end of April, and I lost a lot of my plants.
I'll tell you
But
what my great grandmother's rule, which I follow religiously, is if you live in northeastern Pennsylvania, you cannot put your plants out or plant anything until Mother's Day.
yep, that's
No
kind of
matter
what
how much you think it's going to work, it's not. That was
I actually completely agree because I have done this last year. It was gorgeous, and we went and brought it and planted it, and half of my plants died, and I had to go and get back all my kind of flowers again. So this time,
my great grandmother moved to northeastern Pennsylvania from Hawaii. So she
ah,
Oh,
had to figure
wow.
out how to do everything that she always did in the
that's right,
cold. So so you know,
absolutely.
at least we have a gorgeous day for a very important conversation about women's heart health.
That
And
is
we are so excited to have your friend from Lehigh Valley Health Network join us tonight. It's going to be, I think, a very important conversation. And thank you, Ranju, for coming up with it.
my pleasure. So it is my great pleasure to introduce Dr. Deborah Sandloff. She's a great friend of mine, my buddy in crime, whatever we do together. And she's a is an awesome cardiologist at Muhlenberg campus with Lehigh Valley Health Network. But she's a pioneer in multiple things. So, kind of just in a short introduction, she's the one who started the Women's Heart Clinic in the Lehigh Valley area. So, when I had joined the practice here in the Lehigh Valley area 2008, she already had a hearts clinic, women's heart clinic there. And then in 2015, 2016, she started with me the cardio-oncology clinic. And that was actually, I have to be honest, was the brainchild of Deb. So welcome, Deb. And I think it's very important to talk about women's health, the health of the heart, I should say.
Yes. Thank
Um,
you so much, Ranju. Those are such kind words. And I have to say that Ranju is amazing, so smart and amazing. And I'm so glad to partner with her. And most people don't realize that the heart and cancer intersect. And I think that's a very important topic nowadays. I know, a lot of women don't realize that heart disease is the number one killer of men and women. Most women, when they're asked, fear breast cancer more. And, breast cancer is very important, very, very important. But we have to realize that 1 out of 3 women will die from some form of cardiovascular disease, whereas 1 out of 27 women will die from breast cancer. So we want to keep the women in our community healthy. And part of that is helping them learn about heart health. We know that the more that women understand, the more that people understand, the more they're willing to take care and take ownership of their health.
so Deb, we will not go into the cardio-oncology kind of right now because I want to talk about women in general. So for a healthy woman that we have, who eat well, who are not overweight, when should they start thinking about their heart? So, I'm in my 40s.
Right.
So what should I be doing? When should I start thinking and seeing you guys or not see you guys? And what should I be doing?
So Ranju, that is a great question. And I have to say that it's never too early to start looking at your heart health. And what people don't realize is that there are some risk factors that are atypical. We know about the major risk factors that are very common, like age, family history, smoking, overweight, inactivity, diabetes, hypertension. But we also have to think about these atypical risk factors that are unique to women. So one of the things that we look at in our Women's Heart program is when women go through pregnancy, you have to think of pregnancy as kind of like a metabolic stress test. And if a woman becomes pregnant and develops a pregnancy-induced complication, such as high blood pressure, preeclampsia, eclampsia, or gestational diabetes of pregnancy, they're at greater risk to develop cardiovascular disease earlier on in life. Not only that, the baby born to that pregnancy is also at greater risk to develop cardiovascular disease earlier in life. So we have a chance to really affect 2 generations. So in our Women's Heart program, we're trying to help women in our community learn at a young age how to develop healthy lifestyles and decrease their risk factors so that when they want to become pregnant and when they are pregnant, they have a lower risk of developing these pregnancy-induced complications.
Wonderful. So I think that's a great start to our talk today. So let's kind of start from that. I was kind of thinking which age group to, start the
Never too early.
Never too early. That's right. But I think I'm young enough. So I thought I'll start with my age in the 40s. So let's kind of rewind a little bit. So pregnancy, let's put it, we are now having later and later pregnancies in the 30s, but let's kind of take the usual in the 20s, right? So somebody is in the 20s. What should they be doing? What should they be looking at? Should I have, somebody has a daughter or who's 22 years, 24 years old in the college. So what are the modifications for the lifestyle they should be doing? Should they be doing a cholesterol every year? Should they be checking their blood pressure? I think, diet and exercise obviously is important. We know about it. So maybe we'll start from there, then kind of go to pregnancy and then.
Yeah, so generally speaking, we start checking risk factors at the age of 21, unless you have a strong family history or your parents had significantly elevated cholesterol and you're concerned. But generally speaking, we'll start at the age of 21, start checking the cholesterol. If it's controlled, then we check it every 5 years or so.
Okay.
But if it's elevated, then we want to modify risk factors. We know that obesity and a sedentary lifestyle is a major problem in the US right now. And so, getting our children moving, there's, so many kids nowadays. I mean, when I grew up, probably same as you, Ranju,
Right.
playing kickball in the street, we were playing tag, all those things. Nowadays, there's so much on the computer and iPhones and, those things that we need to really make sure that our young adults and our adolescents and our kids are getting enough exercise and eating a healthy meals or healthy foods. And we know that the type of diet that is the healthiest are things I like to tell people, like, eat it the way Mother Nature made it, not the way Sara Lee made it better, right? So we want you to shop around the outside of the supermarket so that you're getting fresh fruits and vegetables in your kids and your young adults, and you're avoiding those processed foods. And activity is so important. You don't have to be a marathon runner. If you can do 20 to 40 minutes, 4 to 5 days a week, that is wonderful. But if you have goals you need to reach, such as blood pressure or weight or blood sugar, then that number increases to 60 to 90 minutes, 5 to 6 days a week of aerobic exercise. And what I mean by aerobic exercise is something that increases your heart rate for the duration of that exercise. So walking, dancing, aerobics, cycling, something like that, or swimming even. So increasing activity, healthy diet, low on the processed foods, a Mediterranean type diet has been shown to be to increase survival.
Yeah. Putting nuts in your diet, plant-based diet, all those have been found to be very healthy. And I think that I would like to stress that, with everybody behind the computers these days or working, with the computers these days, just having in between those, having those stand-up desks that you can kind of sit and kind of go up and stand during some part of your work day. One of my friends who was in an academic institution just kind of, left that institution and is now going to work from home for NCCN. And she was saying, like, I feel like I'm munching and I'm just sitting in front of a computer because now, there's no seeing patients. And she was saying, what should I do? So we were just, some people were telling her that, have a bike or something next to you in between the meetings, you have 10, 15 minutes, do a schedule, kind of just having 10 minutes of, exercise, or if nothing else, just going up and down the steps. Or taking a phone call while walking inside the house. That's what I tell my patients, that during the pandemic, when they were inside and it was cold, I said, if you're on the phone, don't sit and take a phone call. You just kind of walk with some headphones or just holding and walk around the house. My parents were doing that in India, that they were just kind of walking for 15 minutes or 20 minutes by the watch, but not stopping everywhere to do this or do that.
Right. I mean, my daughter has something fun. I noticed that she's a first-year medical student at Temple, and she, instead of a chair at her desk, she has an exercise ball. So she sits on exercise ball. It's better for her posture. She bounces around, so she's contracting muscles, and that's a great idea instead of having a chair.
Yep. So kind of there, start with that. All right. And then once we kind of, during the pregnancy, not everybody has to come and see a cardiologist or anything. They'll just follow with your OB, and only if they have a complication, they should kind of be coming and seeing you. If they're having swelling in their legs or shortness of breath, that is unusual for the pregnancy, for the gestational age. They should come and see you guys, right?
I had a horrible pregnancy. I wish I had seen a cardiologist during my pregnancy. I never did, actually. But this was 18 years ago. It wasn't in the Stone Ages, but it was 18 years ago, and I was 31. And I had premature labor, so I was on bed rest, and then he wouldn't come, so they induced labor. And during the staying at home and the induction part, I developed preeclampsia.
Oh my God.
So,
oh boy.
Yeah. So I got really sick. And then, I don't know. I mean, we haven't had somebody on to talk about obstetrics yet, Ranju, but I'm one of those people who can't figure out how in 2021, why the whole giving birth concept is still so medieval when people are sick. Like, I was very sick. They decided to induce me. The induction didn't work. They gave me a cesarean.
Okay.
I had a baby that was jaundiced, and then the swelling and the water weight didn't go away. And I literally had a doctor say to me, "I thought you were fat."
Oh boy.
Seriously. So I had the baby on Monday, Friday, they discharged us both. I went home and I went to go to bed at night and I couldn't breathe. And I said to my husband, something's really wrong with me. I have to go back to the hospital. We go back to the hospital. I spend all night in the emergency room. I wind up on the cardiac unit. So, in the cardiac unit, they don't allow your baby to stay with you. So my husband's got a 4-day-old baby in a carrier, and me in the hospital bed, and now a cardiologist saying, well, she's having heart failure. And I feel like I'm not the only one that stuff like this happens to. So
absolutely
when
right.
I was pregnant, I was thinking about all the baby stuff. I wasn't thinking about, oh, I passed my diabetes test, the gestational diabetes test. I passed that. I was good. I kind of figured like, okay, well, now it's all about the baby. And what would you say to women that what do they have to look about for their own health? Because I totally missed the boat and got
Yeah.
really sick, and I literally peed out 38 pounds of water.
Oh my gosh. So that's absolutely amazing. And that is not a surprising story nowadays. And with the incidence of obesity and inactivity, we are seeing things like eclampsia and preeclampsia more frequently. I think the wonderful thing here at Lehigh Valley Hospital is that, previously the different specialties worked in what we call silos. So there's OB and then there's cardiology, and we never really interacted. But now there's so much interaction, so much multidisciplinary care. We have a cardio obstetrics program where our OBs are given, the cardiologists lecture to the OBs so that they have the knowledge about when to consult cardiology, when to look out for congestive heart failure. And really, you just look at what Ranju and I are doing as collaboratively as cardio oncology. So we have cardio obstetrics, we have cardio oncology, we have cardio endocrine, we have sports cardiology for the female athlete. So things that we're doing so that as a patient, you're not being seen in a silo, you're being seen in a multidisciplinary way. And I think that can only benefit our patients.
That's awesome. That's awesome because, well, 18, 19 years ago, my husband carrying the little baby thing, it was funny. It was a Sunday in the hospital, and the cardiologist is saying, well, tomorrow we're going to do this test on her. And my husband looked at him and said, can't you do the test now? And the doctor's like, well, the technician isn't here. And my husband looked at the doctor and said, you know how to use the machine, right? And the doctor said, well, yeah. He goes, well, you're going to go get the machine and you're going to do the test right now, or you're not going to make it home. And they said, okay. The doctor turned around and went and got the machine and brought it back and did the test. And I was really lucky that it didn't do like major damage. But I think that there was a lot of disconnect. And it's great to hear that that's not the case anymore because, fast forward 19 years to hear that would have solved my problem. So it's great to hear.
Yep.
So just like, Deb said, that the fact that you had preeclampsia puts you at a higher risk of developing some complication. And Deb can kind of tell more, since I don't want to kind of say anything incorrectly as to why the heart failure develops in pregnancy. And she can also tell you whether you need any workup to be done or follow up. Just because you develop the heart failure after the pregnancy, you may not have any other signs. But we'll kind of have Deb talk about that. What should you be doing?
Yeah, it is something that I'm concerned about. Like, what should I be doing if my doctor has not mentioned it yet? I'm going to be 50 this year. That's why I am in our last big thing. We talked about colonoscopy, so I'm due for that. I'm due for that this year. So, what else should I be doing or asking about? Because Holly, I had that happen.
Yeah, I think it's number one, great that you shared your personal story, and thank you for doing that, because sometimes it's hard for people to share a personal story, but I think that'll help other people learn about what they need to do. So because you had preeclampsia during your pregnancy and heart failure, you are at increased risk to develop cardiovascular diseases earlier in life, and so is your son that was born to that pregnancy. So we should do everything that we can to ensure that you are leading, a healthy lifestyle. So you should have your cholesterol checked. You should have a good history and physical by your family physician. And if there's anything that shows up as abnormal and your family physician feels like you need to see, or your PCP, because a lot of women use their gynecologist as their PCP. And so you need to make sure as your own advocate that you ask your primary care physician, do I have any risk factors for heart disease? Because let's be realistic. the number one killer of men and women, like I said before, is heart disease.
Mhm.
So we want to identify those risk factors. We know that 80% of cardiovascular events could be prevented by modifying those risk factors, not by taking a pill or anything like that, just by modifying those risk factors.
Mhm.
So if you can first step, identify, second step, do something about it for you and your son. Your son, you said, is 18 now. So
18,
yep. So we should ensure that his blood pressure is normal, that his cholesterol is good, that he's not at risk to develop diabetes, that he has a good lifestyle.
I created this child that is 6'3" and 170 pounds, and he works out all the time, and he runs long distance for cross country, and it's absolutely bizarre that he is my child. I don't know how I did that, but he actually does go to the doctor regularly. About a year and a half ago, he was diagnosed with Gilbert syndrome. We went through a period of time where he lost about 25 pounds and was relatively sick. And through that diagnostic process, he became, a regular doctor goer as now that he's an adult. So he actually is in a regular
That's great.
That's good. That is
checkup
great.
routine already
So it
as a young
sounds
adult.
like number one, he has a very healthy lifestyle. Number two, Gilbert syndrome is a benign elevation of the bilirubin, so not anything to worry about. Thank goodness.
Mhm.
So
It was
that's
his
good.
poor diet and lack of sleep that caused him to have this horrible flare. But now that we know what happened, he's great. He's great. But because of it as well, it kind of got him in the groove of getting his blood work done and going for a physical and all
Right.
of
So
that
that's
stuff.
very, very good. That's
And my
very
son
good.
also, he's been very regular. Kind of from a strict mom that way, that all my kids have to go for their regular appointments. And even though my son is an adult, whenever he visits us, I make sure that he goes for his yearly visit, gets his blood work done. Sometimes they're dieting, and then he's using all those whey proteins and stuff like that. And at times it's hard to control them, and I get worried. There's just so much protein, and then seed protein or whatever he takes. So I'm like, I want you to have your kidney function test done, just so that everything is fine. So it's kind of good to tell our kids that it's okay. They don't have to be mature about it, that they are indestructible right now.
Right. That was kind of like we were very lucky with his diagnosis. I know that. And, but it was at the same time, it showed him that he is not Superman.
That's right.
So I think he'll be like, pretty much on par. I just was wondering, are there any tests that I should be specifically having at my age now?
So, for you personally, I would make sure that you have a good history and physical, make sure your blood pressure is controlled, your blood sugar is controlled, and your cholesterol is controlled. And that you're doing the things, in your lifestyle, such as, a Mediterranean type diet, as well as exercising the recommended amount.
Cool. Well, I can do that. I can do all of that.
Awesome.
I can do all that.
Because we know.
Actually, I know my blood sugar is good. Unfortunately, my husband's diabetic. And every once in a while, he tests my blood sugar just because, and it's always perfect, which makes me very, very happy. Good. Very, very happy. And I did have slightly elevated blood pressure at one point in my life, but I lost a lot of weight, which took that away completely. So the minute I realized that I needed to lose 20 pounds, to get things under control, I happily did it, because I'd rather lose 20 pounds and be healthier longer and not have to take any medication. That's excellent. That. But I think a lot of people who are out there who might be watching this kind of get out of the regular physical, regular doctor visits, regular, things, and only go when there's something wrong.
And that's not a good idea, right? But most women will at least see their gynecologist once a year. And so talk to your PCP and ask them, what are my risk factors? What do I need to identify? And I'll tell you a quick story. I was walking through the Cancer Institute last year, and I saw this magazine on the table, and it said, "We found the fountain of youth." And I was like, "Ooh, stop, back up. I want to know what the fountain of youth is." So I opened up the magazine. It was one of our Healthy You magazines, and it said, and it was a picture of a pair of sneakers. And that is absolutely true, that we know that exercise really can decrease your risk of a lot of different chronic illnesses, including cardiovascular disease, including cancer, including dementia, including, so yeah, Fountain of Youth, exercise.
Deb, so you
We've
talked
talked
about
about that a lot. We've talked about that a lot, Ranju, lately, because since we've started this show, this series, we've talked a lot about COVID and what it has caused to people, and how people have gained more weight and exercise less. Ranju has talked about it a lot, about getting yourself going. Do you guys think that people are kind of coming out of it?
a little bit, yes.
I hope so. I mean, I do think that people have a lot more free time on their hands than they did before the pandemic, because we're not doing as much, outside the home. And this is the time, the weather's getting nicer. Now is a great time to start an exercise program.
Yeah, in my clinic, I saw that the first, the 2020 people were all gaining weight. Then the holidays came, right? Then the winters kind of came. And now I see in the last month and a half, that people are more committed to kind of, okay, now it's time to go and do the yard work, to walk, to hike. So I think that people are getting kind of ready to go and exercise there. Deb, the next one that I would like to know, and for my own self also, you just talked about sports and cardiology, right? I think, I hope that there would be a lot of women athletes of any, whether they are men or women, but since we're talking about women, so the girls and women. So why do we need to have cardiology in such a young age group? Can you talk about it? That's
such a great question, Ranju. So we do have a sports cardiology program here at LVHN. And it really started initially because of COVID and getting our athletes back to play. We call it return to play in a safe fashion. And what we realize is that that over 40% of the athletes that we saw were women. And we know that there's something called the female triad, where the female triad is what we see in young athletes, where female athletes don't get enough. They don't get enough calories for the amount of exercise they're doing.
Okay.
And then osteoporosis, and then amenorrhea, where they stop having their periods. And we know that when female athletes have that triad, that they're, number one, they're 8 times more likely to have a sport-stopping injury. And a happy athlete is a participating athlete, right? So if you're 8 times more likely to have a major injury that's going to keep you out of play, that's not good. Also, in the long run, we've realized that these women that develop this female triad can develop something called endothelial dysfunction and increase their risk of cardiovascular disease earlier in life. So we want to ensure that our female athletes are getting enough calories for the amount of exercise they're doing, that they are menstruating appropriately, and that they're not at increased risk for osteoporosis. So it's a great program, and we the sports program has been seeing a lot of the college athletes in the area, even down into the Philly area.
Does the school children also have to go like high school? Or more?
Yes, we have our program has also seen high school students as well. I think we're down to the age of 17.
Okay. And can you talk about, so that's one aspect of it. Can you talk about something about the sudden cardiac death in the athletes? A little bit about that, what are those kind of things when, you've heard of all the athletes, men or women kind of here, who have just suddenly out of nowhere on the field, they just, had passed out, and then lo and behold,
so thankfully that's very rare, but sudden death in the athlete is certainly concerning. And that's why we ask, all our athletes have a history in physical before they're allowed to participate in sports. And some red flags would be if you have a family history of sudden death at a young age, if your school nurse or primary care physician hears a murmur, or if you have an abnormal EKG, that would certainly be something, or an abnormal blood pressure. So that's why we ask our athletes to be screened before they start a competitive sport.
Wonderful.
Well, I think
Holly, we lost you. All right. I hope that we are still striving. So I will ask you the next question. So let's kind of shift gears and talk about the cardio-oncology, right?
Mm-hmm.
So we will talk about why a patient who is undergoing cancer treatment or has undergone cancer treatment, why do they need the cardiologist? They should just need me, right, from oncology, but we are realizing more and more that we need you as well. So can we talk a little bit about the cardio-oncology program?
Yeah, and this has been such a wonderful journey for Ranju and I.
Mhm.
And I think that we have collaboratively taken care of a lot of patients. And there is an amazing intersection between cancer and the heart. And you can start with the fact that the risk factors for heart disease and the risk factor for cancer overlap. And so if I had told you before that if we can modify those cardiovascular risk factors that we had talked about, we could prevent 80% of cardiovascular deaths. If we can modify those same risk factors, we can decrease the risk of cancer by 30%. That's
right.
Pretty amazing. A lot of people, I myself fear the risk of cancer. So also we know that in patients that undergo cancer therapies, that if we control their cardiovascular risk factors, that they're less likely to develop what we call cardiotoxicity, or damage to the heart from some of the cancer therapies that we may want to use, that Ranju may want to use to effectively treat your cancer. Some of those treatments, unfortunately, do have some detrimental effects on the heart. And we know that if we can control cardiovascular risk factors, that we decrease the risk for the heart. And then we know as cancer survivors, that 1 out of 3 cancer survivors will die from some form of cardiovascular disease. So you survive your cancer, we also want you to survive heart disease. So maintaining a healthy heart and effectively treating those risk factors is very, very important. So again, Ranju and I and our program, we don't work in silos. We talk frequently with our cancer patients to ensure that we're not only treating their neoplastic disease effectively, but we're also trying to protect their heart as best we can through the therapy and beyond.
Right. So there are certain chemotherapies that we give, or radiation towards the heart that we have to give. And that's important to treat their cancer, to control their cancer. But we do not want patients not to get the treatment that would save their lives.
Mm-hmm.
So that's kind of where Dr. Sandloff and her team kind of comes in to try to modify, what can we do? Can we add some medications, or can we monitor? Can we control the cholesterol better? Can we control the diabetes better? So they will kind of help us manage those. We, in the last 4 or 5 years, we have kind of really touched about 400, 500 patients with, in kind of commonly between cardiology and oncology there. So this is the only program that we have in the whole Lehigh Valley area.
That is really cool. I mean, that's something that I don't think a lot of people get to hear about. I mean, unless you're in this situation, unless you're going through this or a family member's going through it, that you guys work so closely with each other to make sure that a person can still get their treatment.
Absolutely. So that's kind of the whole idea, to control the risk factors so that the oncology treatment does not have to stop. So I have to ask you a question. So my mother-in-law, had the usual risk factors, lived in a rural area, really did go to the doctors, but only when she needed to be, my blood pressure is okay, and didn't have diabetes. She was in her 60s, and even when she used to visit here, they would get all their blood work done. They were okay. They modified their cholesterol. Dietary habits were okay, kind of, her dietary habits, but she was very active for her age. And she would always be calling about, I'm bloated, I'm bloated. I have what we would say in my language about like gas, how belching and platters and all of that sort of things, and would be going to and taking all these pepsids and all of that part. And then lo and behold, something happened. They didn't even tell us because they didn't want to, worry us. And then she had a 4-vessel disease and required
My goodness.
a bypass surgery done. And she never had a chest pain, nothing. And I think I worked as a senior resident before I came to US. For 2 years, I used to be in the ICU attending at that time in India. And I still remember I was a young attending, and there was this woman, middle-aged woman, slightly overweight, and who kind of came in with nausea, vomiting, kind of epigastric pain. Epigastric pain means like kind of pain just below your breastbone here, right? And the first thing we thought was gallbladder disease, right? Kind of most common place. And, I ordered an ultrasound, and then I'm looking from the eye here because I was in the emergency room, and in India, it's kind of crazy emergency room. I mean, that's kind of, you see about 100 patients in 6-7 hours. It's that busy. And I'm looking from the side of my eye, and she just doesn't look right. Her breathing doesn't look right. So I just kind of said, let's just get an EKG done till the tech kind of comes for the ultrasound. And lo and behold, she had an inferior wall, a heart attack, basically. And then we had to send her to the ICU. And really, this is not the first time we have seen that. I think, Deb, you would agree that in women, a lot of atypical presentation can happen for the heart attacks, that we kind of keep thinking it's belching or flatus or gallbladder disease. And there's a little bit of a delay in the diagnosis. So can you kind of
that's
go
a good
ahead and
point.
tell?
So when we talk about typical chest pain, when we read a textbook and we say, what is typical angina or chest pain when someone's having a heart attack, it's generally what we would say is substernal chest pain. That means pain underneath the breastbone. That's a pressure feeling that's brought on with exercise, that's relieved with rest, and usually lasts between 10 and 20 minutes. Well, that's typical. So women are more likely than men are to have what we call atypical symptoms. They may have more GI upset or discomfort in the upper back or discomfort in the neck or jaw, and maybe brought on with emotional upset and not necessarily physical exercise. And so we want to tell our women that if you have any type of discomfort between your nose or navel, you should get it checked out.
That's right.
And most people say it's not a pain, it's a discomfort. It's funny because, I've never had a heart attack, so I can't discern the difference between that, but I can't tell you how many times that a patient says, well, it's not pain, it's just a discomfort. It's an uncomfortable feeling. So most women will say, I just knew something was wrong.
Yeah. I mean, this woman, I don't think so I will ever forget. This patient was having pain, just like the GI pain, and nausea and vomiting. So really, my first diagnosis was that this is all a
gallbladder. Yeah.
And so many times it's not gallbladder. So I really want to tell our audience who is listening that please do not ignore whether it is a gallbladder pain or it is a heart pain. You got to get that checked so that we can kind of figure that out. And if we need to do an EKG is all we need to kind of, diagnose one way or the other.
Right. And I have to say that the majority of people that come to the emergency room that are having some sort of discomfort, it's not a heart attack. But you know what? We are glad you're there, and we can identify risk factors. We can talk about that. And so we're never going to say, you shouldn't have come. You should come. If it doesn't end up being your heart, we can always identify risk factors for you and help you modify those.
So
I think we touched on it briefly, but could you kind of break it down a little bit better for our people out there, because men and women can have different symptoms.
Right.
And we're very used to hearing the symptoms that men have.
Well, So let's be clear that the majority of men and women have typical symptoms.
Okay.
Okay.
Okay. So it
that's
would be the pain
substernal
in the
chest
arm.
discomfort, radiating to the arm
Mhm.
or radiating to the neck.
Okay.
But women are more likely than men are to have what we call the atypical symptoms, like Ranju brought up, where it's more like feels like it's more in the abdomen, maybe, and then radiating up maybe to the chest, to the shoulder, to the neck, to the jaw, maybe in the upper back, and associated more with emotional stress and nausea, vomiting, those types of things.
And one other thing that has to be kept in mind, some people will get upset that they went and everything was fine, but that's a good thing, right?
That's a good thing. We're
that's a
glad
good
you're
thing.
there. We are
Right. So
glad you're there.
I always tell people that when they have a symptom, and that, get it checked, because you don't want to miss the things that can kill you, right?
Exactly.
So if there is a pain and you don't want to miss a heart attack that could potentially kill you. If it's not
That's
that,
right.
then we can figure it out, whether it's a gallbladder, whether it's just a acidity, gastritis, we can take care of it, but you don't want to miss something that could kill you. So it's okay to go and say that you don't have a heart attack and you have to come back from the emergency room.
That's right.
So
And
there's nothing
we
to
can
be upset
identify
about.
those risk factors and we can
Yep.
help modify those. It's a good thing.
Yep. So it's a good thing.
We're happy you're there.
Yep. So it's not that we are trying to do excessive tests. We just want to rule out the bad things that can happen to you. Yep. So that's kind of where we are. So I think we touched about the symptoms for the heart attack. We talked about, so I think one of the other things that we have to talk about, Deb, is congestive heart failure. So we talked about sports, we talked about pregnancy and heart, we touched a little bit about, cancer and heart. We talked about the chest pain, and a heart attack. So I think the one big thing that is still left behind is the heart failure. So I don't think so there's anything specific, or if I'm missing something specific related to women, that's fine. But in general, what should people be doing, not doing, a little bit of, common things that you tell your patients when you see them.
Right. So congestive heart failure is a huge topic. It also is a huge problem. In the United States, it's the #1 leading DRG diagnosis that we admit patients for to the hospital. So generally speaking, congestive heart failure is when your heart is unable to effectively pump the blood forward to generate blood flow and oxygen to your vital organs. Typically, the symptoms of congestive heart failure are shortness of breath, weight gain, swelling of the legs and the abdomen. A lot of times, the reason why patients may have heart failure is because they had a heart attack before. But sometimes they can have heart failure because their blood pressure isn't well controlled. Or it sounds like, Holly had heart failure because she had preeclampsia and her blood pressure was probably very high. So her heart was unable to pump the blood effectively forward, so it backed up into her lungs. So it's very important for our heart failure patients to see their heart doctors regularly, to identify why they have congestive heart failure, and try and treat the underlying reason if that's possible. Sometimes it is, and sometimes it's not. A lot of times it's about maintaining their blood pressure control, making sure they avoid salt and too many fluids. And again, ensuring that you take your medications regularly, because we do know that there are some very good medications that can improve not only how you feel, but improve the length of time that you live with congestive heart failure. So those are important things to discuss with your doctor.
Perfect. So I think I'm just thinking in general, we covered all the major aspects of cardiology, I think, with the heart. I had some other thought that came into my mind and I just kind of slipped that.
It's the beautiful day. It made us all not focus on things.
One of the questions I get asked a lot in India is, what is the right blood pressure? So what are we kind
Oh
of
my
looking
gosh.
at 120,
that's a good
80,
question.
140, 80, 140, 90? We kind of have all these guidelines going left and then right, right? Kind of, I don't know anymore.
Right. So, that also depends on how old you are, what underlying risk factors you have. But ideally, an ideal blood pressure is in the 120s over 70s.
Okay.
That's ideal. But
Right.
again, the goal will depend on what your underlying risk factors are and what your age is.
Okay. And so some people who would be a diabetic may require to have their blood pressure at a lower level for optimized kind of functioning of the heart compared to somebody who's 21 years old with no other risk factors. And
Right. Or if somebody is older, we allow the blood pressure to be a little bit higher. Or if they have kidney disease, we may allow the blood pressure to be a little bit higher because we want the kidneys to see enough blood flow. So there's no black and white answer to that. But definitely talk to your doctor. They should look at you as an individual, look at what your risk factors are, and determine what the best blood pressure and cholesterol is for you.
Okay, I'm going to put you in a spot, Deb, now.
Okay.
Don't hate me for it. All right. So there was a time, I think about, I would say about 20 years ago, right? We said everybody who's above 40 should take a baby aspirin.
Oh,
Yeah,
that's good. Right.
It will prevent a heart attack. It will be good for your heart. And, once you reach 40, kind of have your aspirin ready.
Yes.
And we are not doing that anymore. So I actually bought an aspirin and I had started taking when I was, 2-3 years ago, not always kind of compliant because, I don't need it for that reason. But I really kind of thought that aspirin would be something that would be good for so many things, and say some data in cancer also. And then all that data kind of came by and I stopped taking the aspirin. So can you
That is correct. That is true, Ranju. I'm glad you brought that up. It is true that we used to say, okay, anybody over 40, start aspirin therapy, but that we learned that actually the risk of bleeding may outweigh the benefit. So that is something that also should be individualized. And we really only ask patients that are at risk for cardiovascular disease to take a baby aspirin a day. So that has definitely changed. We don't ubiquitously order it in everybody who's over the age of 40 anymore. If you've had an event that is a stroke or a heart attack, we do feel that aspirin therapy is beneficial unless you're on a different blood thinner for another reason, then that needs to be discussed. But for what we call a primary prevention, that is that you haven't had an event before, that's something that should be individualized. We also know that a baby aspirin a day also decreases the risk of colon cancer. And
that's what I said.
Yep. So sometimes we do look at that in certain age groups and patients with risk factors. But again, we don't recommend it as a blanket statement for everybody over the age of 40 anymore.
Any supplements that you would recommend kind of from a cardiac point? I mean, these are the questions that are most commonly everybody's mind, and we are trying to kind of answer those questions.
Right. That is a great question. And so when we look at the different supplements, we know that if you look at calcium, is there a risk of coronary calcium from the calcium that we take or the calcium that we eat? And the answer is that we should really stay within the recommended amount of calcium. We know that there are two things that disable women: cardiovascular disease and osteoporosis. If you're over the age of 70 and you break a major bone, you have a 50% chance of not returning to independent living. So we know that we want to prevent osteoporosis. So the amount of calcium that's recommended, you should stay within those guidelines and not go above that. And we know that calcium and vitamin D are important for our bone health. So those are great supplements, and stay within the recommendations from your physician and don't go above that. When we look at medications like fish oil, so there's kind of been a change in tide with fish oil. in that we would prefer as cardiologists that you get your fish oil from your diet, from olive oil, your omega-3s from fish, and from the fatty fishes like tuna and salmon, those sorts of things, and olive oil and avocados. But if
It's
you,
good that avocados and olive oil are on your list, because
Yeah.
I know salmon is good for you. I know it.
yes,
I
Mhm.
cannot eat it. I
You
have
can't
tried
eat-
it 8 million ways. I find it to be, I'm just one of those people that it's been cooked for me by different people in different ways. I just think
yeah.
it's so disgusting. So no, no.
There's a saying in cardiology, get it from the land, the sea, and the olive trees.
Well, I like
So-
the olive tree, so I'll
Mhm.
And me too. We are vegetarians, so no fish for us. So,
Mhm.
so the avocado oil, and olive oil is
I
very
love avocado. You know,
Yeah,
you hear people,
land,
so I'm one of
sea,
those
and
people who loves
olive
that. You
trees.
hear people say, oh, I hate avocados, and you stand there and go, how can you hate an avocado?
It's true. But the other supplements, such as vitamin E, has not been shown to be beneficial. Vitamin C has not been shown to be beneficial. So there are really not a lot of supplements that have FDA approval for improved morbidity or mortality.
Don't you guys both feel that a lot of people take a lot of supplements
Yeah.
that just to take them? Like there's not necessarily like, you know
Data to
people that
support
have
it.
like 27 supplements on their
It's true.
counter. You know what I mean?
It's
And
true,
it's like,
yeah.
so my husband was recently prescribed. He's been sick for a while, and we finally found a fabulous endocrinologist who's doing amazing things with him. But because he's 47 and he acts like he's 80, which we had to find some solution to along the way. But the doctor prescribed vitamin D for him,
Mhm.
which I thought was really interesting.
Yeah, so most of us are vitamin D deficient.
Mhm.
You know, it's very hard to get enough vitamin D from the sun.
Mhm.
So, you know, a lot of us are vitamin D deficient, and we know that that affects a lot of different organ systems. So it
All
is,
over, yeah,
Pretty much everything.
everything.
so it is very important to maintain an adequate vitamin D level, as well as a calcium level.
And we are using all these sunscreens and everything else, so they will decrease your ability to absorb the vitamin D. We still don't know what is the most accurate level of vitamin D that we need.
Mhm.
So majority, I mean, I think more than 3/4 of the people are vitamin D deficient unless they're taking some sort of supplements
Mhm.
that they would take. And yeah, so my general spiel for people when they talk about supplements is like, you have a cream that they will say, this cream, when women applied in a clinical trial, women applied this cream and 90% of them had less wrinkles or lines
Mhm.
on their face.
Mhm.
And
Mhm.
how many people did that trial? 10 people.
Yeah, right,
Kind of
right.
that's kind of the data that they have. That after 4 weeks, they had less, wrinkles and fine lines on their face. So that's kind of the trials that are mostly done with all these supplements. But people who tend to believe that. And Deb talked about that we should really eat the food in the original form, kind of,
Mhm.
from the soil, from the farm to your mouth. And if we do that, we will get all the vitamins that you need from that. We don't really need to take any supplements. And that's actually a better way of taking the supplements rather than taking them the way, even now for the calcium. If you can have enough calcium in your diet, you really don't need to take a calcium supplement.
Well, I think that's the big problem all around, is that we don't exercise enough. We don't spend enough time in the sun. We don't eat right. We don't. That's why we need you guys, unfortunately. So I think really we came across today saying to people, make sure you see your physician and get appropriate tests for you. Make sure you look into appropriate
Know your
supplements
numbers, know
for
your
you.
numbers.
Yeah, and get moving. Right?
That's right.
Absolutely. Get moving.
Well,
Get
the
moving.
best thing is to get moving. That's the only part that I want people to kind of get away with. So if we can motivate some women to get moving, then this was.
We kind of say that at the end of every month when we do this show. It all comes around to eat healthy, see your physician, do what they say and get moving. So again, I think we're going to end another show with everybody needs to get moving however that works for you. So
Right. Fountain of youth, a pair of sneakers.
a pair of sneakers. That is a great thing to leave
That's
with right
right.
now, Deb. Thank you so much. We had a great night tonight. If you have any questions, you can reach out through chat, and I'm sure Dr. Gupta will make sure that we get you an answer. We need to thank our sponsor again, My Girl Managed Services. Jen Markovich and her team will make sure that your business is seen so you can have better Google presence, better website, and a better social media program for your business. New and old, make sure you check out My Girl Managed Services. We will be back again in about a month at the end of, oh my gosh, May. At the end of May with our next health chat series installment. We aren't sure what we're going to talk about yet, but I'm sure it'll be something fabulous because Dr. Gupta always comes up with great ideas. Thank you, Dr. Gupta, for coming up with this idea. Ranju, we've known Ranju for like quite a while, and this was her idea really in the end when it comes down to it. We love talking about health, women's health. We hope everybody who's watching tonight stays safe and healthy and has a great week.